Thank you, Governor. I appreciate the recognition, um, and I appreciate the opportunity to talk to all of you. I'm fortunate that the Vice Chancellor of our university is not here to hear this because the title of my presentation, I wanted to talk to you about 3 things that I learned absolutely nothing about in medical school. Okay, the first of those is public speaking. If I had been told that we had to study public speaking in medical school, I probably would not have applied. I would have chosen a totally different career. But in fact, I made it through 30 plus years of practicing medicine without needing to know anything about public speaking. And a bomb went off in my life about 5 months ago. So I'm mentioning this today just as a warning to any of you older docs out there who are comfortable in your practice of medicine and you feel like you're in a routine that will continue into your retirement. The warning to you, what I've learned in the last 5-6 months, is that if you stumble upon some major finding, change your name or adopt a pseudonym before you report it. Okay, the next thing that I learned absolutely nothing about in medical school was economics. And so when Clay asked me to speak for an economic conference, I was rather puzzled. My introduction to economics actually occurred when I was in college, and that was because my best friend was an accounting major. Now, I overheard enough of the study sessions for the micro and macroeconomics courses that I knew that stuff was way above my head. I did the expedient thing and married my accountant. That has worked very well for me. And it may not work well for everybody, but I just wanted to throw that out as a tip for any young docs that are in here who are still single. The third thing that I learned nothing about in medical school was HIV disease. Now, that statement dates me. Yes, I finished medical school in 1980. And in 1980, there was kind of a beginning of a recognition of some kind of syndrome that caused an acquired immunodeficiency. Nobody knew exactly what it was. Nobody knew exactly how it was transmitted from person to person. There was just kind of a blank slate there. HIV was not named at that time, and so I learned nothing about HIV when I was in medical school. I'm pointing this out to you not to tell you that I'm that old, but to tell you that there has been a remarkable expansion of the body of knowledge in just 30 years on this devastating disease. And so I want to tell you a little bit about the pediatric perinatal HIV here in Mississippi over the last 19 years that I've been involved with it. So our pediatric perinatal HIV program at the University of Mississippi covers the whole state. And this is a success story. Now, most people think that the success of our program has been wrapped up in the functional cure of this little girl. In actuality, I'm much prouder of what has happened over the last 20 years in this program, not in cure, but in prevention. This graph, and as I understand it, economists and doctors all love graphs and stuff, so I've got a lot of them in here for you today. This graph shows the number of perinatal transmissions in the state by year from 1990, I think, through 2013. And you can see that we were having 8, 9, 10, probably more than that, but those were the ones that were recognized as newborns back in the early 90s. The first diagnosis of pediatric HIV was diagnosed in 1987 in Mississippi. And at that time, and in the early 90s, when a baby was born to a mom who had HIV, and when the baby was diagnosed as being infected, we had to sit down with that mom and say, okay, we found that your baby is infected with this disease, and we will try to keep your baby healthy for as long as possible, and then we'll try to keep your baby comfortable. But we knew that that child was likely to die before reaching their teen years, and almost certainly would die before they became adults. Fortunately, with the expanding body of knowledge, HIV has now, long since, for a decade, has been not a universally fatal illness, but a chronic treatable illness. So today, for the last 10 years, as a matter of fact, we've not had to say that same thing to parents. We've been able to say, we'll treat your baby and keep, as long as the baby stays in therapy, does all the right things, your baby has real good chances of living a normal, healthy life as long as they keep taking their medicines all of their lives. So you can see that over the time, that amount of transmission from mother to infant has decreased drastically. Those last few bars where you see the red bars, the one in 2010, and well, actually, all of those, there have been 8 in the last 12 years that have transmitted in Mississippi. And every one of those was a failure of our transmission prevention efforts. Every one of those was a case where the mom, for one reason or another, was not in prenatal care and did not take medicines through the pregnancy. So our effort in the Pediatric Perinatal HIV program has been to try to prevent transmission from mother to infant. This slide shows you some more bars. The blue bars are the actual transmissions. The red are the number of women who were HIV infected at the time of delivery. So you see that as the number of transmissions goes down, the number of women has been going up to, and I don't know what happened in that what was it, 2003? I wish we could replicate that, but it went up to a peak, and now you're seeing a trend coming back down. So this is another success story where you're having fewer women, we think, who are HIV infected, who are delivering infants. Now, this slide just shows, it's the same as the bar graph that I showed you initially of the number of children who were, where HIV was transmitted per year. But I put it as line graph because some people just like those better, but mainly because I wanted to show you some things that have happened at certain points along that thing. The big event in prevention of perinatal HIV occurred in 1994, and that was the interim analysis of a large clinical trial that was going on across the United States called PACTG, that stands for Pediatric AIDS Clinical Trials Group. It was protocol number 076, and what they had done on that protocol was take a big group of women who were HIV infected and who were pregnant, and half of them were given treatment with AZT, or properly called zidovudine, but most of us know it as AZT. Half of the women were treated during the pregnancy with AZT, and their babies were treated for 6 weeks after birth. The other half were in a placebo group. In February of 1994, the Data Safety Board was looking at the data as an interim analysis and found that the transmission rate in the placebo group was running about 25%. In the treated group, transmission was down to 8.3%. So that was the major breakthrough. So we found in early 1994, found out that treatment of women during pregnancy could prevent transmission to their babies. Mississippi was primarily spurred by the health department, was very proactive in getting this implemented in Mississippi. So by September of 1994, I was hired, and the big portion of my job was to start implementing this program. So you see the graph started down at a rapid rate just with beginning to treat women during pregnancy. Okay, next big event in our program. To begin with, I was treating the kids who already had HIV disease, so I spent my time in the pediatric clinic treating those HIV-infected kids. And at the same time, I would run over to the OB clinic to see a woman when she had been diagnosed with HIV, or when an HIV-infected woman had been diagnosed as being pregnant. And I would run over there and I would say, okay, you need to take this AZT, and here's your prescription, and I'll see you at delivery. And that obviously was not the best form of patient education. And so in 1999, we hired a dedicated nurse case manager to work with those women throughout the pregnancy. And then in 2000, we hired a dedicated physician to treat just HIV-infected women during pregnancy. And that gave us a boost to compliance with taking the medicines during the pregnancy. And you see again, the graph took another dive. Then a date range there. We've found more and more drugs besides AZT that were effective at bringing the mother's viral load down, so that it increased the efficiency at preventing the transmission. And this has continued to develop. The medicine of it has continued to develop to the point that now essentially every case where a mom is treated during the pregnancy and gets good control of her viral load during the pregnancy, it is very extremely rare for a baby to be born with HIV. So then other developments that we've done in our program, we've hired additional case managers and nurse practitioner who sees most of our babies in clinic through the testing process, which is up to age 6 months. And we, over the years, have had collaborations with a number of different agencies, and those have been essential to us being able to be successful at prevention of perinatal transmission of HIV. Collaborators are myriad. The big one has been the Mississippi State Department of Health. Now, I worked for a number of years with the clinical trials group, the Pediatric AIDS Clinical Trials Group, and very often in dealing with these investigators from other states, they kept asking me, so how do you manage to keep up with all these babies over the whole state? You know, how does this work? They couldn't keep up with their own babies just in a central locality. And I got to say, okay, number one, we've got a very active health department. Number two, the fact that we're a rural state is actually to our advantage here. I have had more than once a local health department nurse call me and say something like, Dr. Gay, you remember Miss Jane Doe? You followed her baby about 2 years ago. Well, I saw her in the grocery store today, and she sure did look pregnant to me. So I know where she lives, and I'm going to go by her house on the way home from work tonight and have her come in the health department tomorrow for a pregnancy test. You know, that doesn't happen in Miami, but that can happen in Mississippi. So our rural nature is actually an advantage to us in a lot of ways. And we have a health department that is out there in the communities. They know their communities. And furthermore, they care about their communities. I can't tell you the number of times every week that I or one of my case managers talks to a social worker or a nurse or a DHS worker or somebody who is saying, how can we help you to get that baby back into clinic? Or how can we help you to make sure that the baby is getting their medicine? Just last week, talking with the DHS worker, we've got a baby that's ready to go home from the nursery, but the mom is not unwilling to care for her baby, but she's not very able to care for her baby. And so DHS is going to be sending a family preservation specialist to do home visits. At the same time, the health department is going to be through the PREMIS program, the perinatal high risk management. They're going to be sending a nurse to help her learn how to take care of her baby. And there are workers all over this state that care about their communities. They care for their babies. And that's not an advantage that a lot of states have. It's one that we need to capitalize on because we do have it here. The Bethel Regional AETC, that's an AIDS Education and Training Center, and they've helped to get us out across the state to be able to talk to doctors and nurses in places all around the state. Mississippi Medicaid, even with all their stringent rules, they have helped us in many different ways to be able to do what's needed for this specific population. I mentioned DHS and the children's services and youth courts, private hospitals and outpatient physicians. We work as consultants with pediatricians and with OBs all around the state. The current guidelines for the pediatric HIV care that come from HRSA run about 350 pages, and then the perinatal guidelines another 250 or so. So we can't expect that every pediatrician and OB can keep up with all of the changes in this rapidly expanding body of knowledge. We can serve here at university as consultants to help them be able to take care of the patients adequately in their areas. So let me give credit where credit is due. These girls are my case managers and nurse practitioner, my data manager, and they do all the hard work. They're the ones that develop the relationships with the moms. They encourage the moms. They help the moms overcome barriers. When necessary, they cajole and nag and threaten. They do whatever is required to make sure that the moms can take their medicines and can prevent the babies from being affected. Now, I've been very excited this morning to hear so much about prevention. And I'm glad to know that a lot of people in our state are excited about prevention. That's not always the easiest part of medicine, but in so many ways, it's the most profitable part of medicine is prevention. That's what we're all about in our pediatric HIV program. Now, I don't want to disappoint the governor, so I want to tell you a little bit about the Mississippi baby. You see the circle around that 2010. So every red bar on this graph is, to me, a failure. So my 2010 failure was a baby who was born in an outside hospital. Mom had not accessed any prenatal care, and she came in labor. They did the right thing by testing her when she came in labor. This is current standard of care. Actually, standard of care in all of the Deep South is that every woman be tested for HIV at the first prenatal visit and a second test done during the 3rd trimester of the pregnancy. And if those are not documented, then when she comes in labor for delivery, then she's tested at that point. So she was tested, and her screening test came back positive. Now, the first step on an HIV test may be positive, especially in pregnant women. It could be a false positive. So the first step, the screening test, came back positive on this woman, but there was not time to intervene for her baby, so she delivered the baby. And the next day, the baby was transferred to UMC. There were some other neonatal problems, and they felt better about having her at a level 3 hospital. So I became involved with the baby at age 30 hours when she arrived. We knew that by that time the confirmatory test had come back on the mom. That showed that the mom was infected. We had no idea what mom's viral load might be. We knew that she had not been treated during the pregnancy because she didn't even know that she had HIV. So we started 3 drugs as post-exposure prophylaxis. Now, our usual post-exposure prophylaxis is using just AZT for the first 6 weeks of life. We use that in cases where mom has been on treatment, so the risk to the baby is very low. This was a high-risk case, and I chose 3 drugs. Despite what you've read in the lay press in recent months, that actually is not terribly unusual. A lot of people were using 2 or 3 drugs, and actually since 2010 there have been some clinical trials that have shown using 2 or 3 drugs as post-exposure prophylaxis gives you better efficacy than using AZT alone. So it is now standard of care that you use 2 drugs, at least 2 drugs as post-exposure prophylaxis for these babies. But for this child, we started the 3 drugs at 30 hours of age, and we drew the test just before starting the drugs. Within a week, we knew that the baby had actually already been infected. I felt terrible. I had pledged to myself that we were not going to have any more transmission in Mississippi until after my retirement. And that little blip right there on the 2010 bar was a failure in my account. However, we had her on 3 drugs. We continued 3 drugs as treatment, treated the baby for the first year to 15 months of life. Her viral load came down nicely, just as it should on treatment. All of her laboratory studies showed that she was taking her therapy well. And then she kind of dropped out of care. And we didn't know exactly what all was happening. Life had intervened for the family, and other things became a priority over giving this baby's medicine and bringing her to clinic. But because we have the collaboration with the health department, with DHS, I was able to get in touch with the DHS worker in that area and the health department nurses in that area. They went out and they found her. They brought her back into clinic, and I will admit that I severely scolded that mom. She told me that she had not given the medicine in about 5 months. In actuality, we looked at pharmacy records, and it had probably been longer than that. And I told the mother, somewhat politely, that she was basically killing her child. Then I drew the test and got ready. I was getting ready to start the baby back on medicines, but had to wait for some test results to know exactly which medicines to restart. And much to my surprise, the test came back negative, showing no virus in the baby's blood. So I immediately assumed that the tube of blood had been mislabeled, or the lab had switched it in the lab or something. So we called the baby back in, drew another test. We drew several tests, and all of them came back negative. My first response was to panic, thinking that I have been treating an uninfected child for a year, and how much jail time is that going to bring? But I went back and looked at the early test on this child, reassured myself that yes, indeed, she was initially infected, and I realized that I was in over my head, so I called a friend of mine at the University of Massachusetts, Dr. Catherine Lazuriaga, and she called a friend of hers at Johns Hopkins University, Dr. Deborah Prasad, and the three of us started doing very ultrasensitive tests, things that they had available in their research labs, and discovered that we could not detect virus in this baby's blood. We could not detect virus in what we call the viral reservoirs, or what I call for the parents and children hiding places. And so we decided to watch and see what happens. At this point, she has been off of medicine for about 15 months, at least 15 months. She still has undetectable viral load, and she's growing, developing well. She has no symptoms. Her immune system is strong and healthy, just like a normal 2-year-old would have. And we're thrilled that this has happened for this child. We're hopeful that we'll be able to figure out exactly what did happen to this child, and be able to replicate it in future cases. Now, I've told an awful lot of people, I'm getting credit from a lot of people for curing a child with HIV. In actuality, I was not even thinking about trying to cure a child with HIV. I was trying to prevent HIV, and I was a failure at preventing it in that particular case. It was actually God who cured this child, and I just happened to be standing close by at the time. So I want to give credit where credit is due. So since this case, a protocol has been written. It will be conducted, hopefully, enrolling women as early as this fall. Most of those women will be not in the United States, and that's a good thing. I'm hoping that we in Mississippi do not participate at all in this protocol. The reason being is I don't want to have any more infected kids. But on this protocol, women will be, women who have not had treatment during pregnancy will enroll their babies, and they will be given 3 drugs as post-exposure prophylaxis. And if the baby then turns out to be infected, they will continue on the 3 drugs to age 3 years. And at that point, ultrasensitive testing will be done to see if the viral reservoirs have replication-competent virus in the reservoirs. If that test is negative, then they will take the baby off therapy and see what happens. So there will be ongoing studies to see if we can replicate what happened with this baby, and hopefully that will be very helpful to the rest of the world. Most of the babies enrolled in this will probably be enrolled in the developing countries where they don't have nearly as much prenatal care. Here in Mississippi, we're back on track with let's prevent every case. Thank you very much.